Thank you, Steve. Hello, everybody. My name is Rebekah Matthews. I'm an integrated pathway manager at Sheffield Teaching Hospitals. I'm a registered nurse by background, qualified in 1994, and have always worked in community nursing. Qualified as a district nurse in 1999 and have never looked back. Next slide, please. So my presentation today is about the OK to Stay plan that we developed in Sheffield. But before I start, I'd like to introduce you to Annie, who is one of our patients in community nursing. She's an 81-year-old lady with chronic obstructive pulmonary disease, back pain, hypertension, arthritis, angina, and anxiety. So she's a lady with multiple long-term conditions. She's a lady who's socially isolated. She does have family, but they don't live locally. Her community nurses do visit her regularly, but only every 2 or 3 months. She calls 999 almost weekly, and in the last 12 months has had 9 admissions to hospital and many, many more attendances in A&E. Next slide, please. So the aim of the OK to Stay plan is to help people like Annie, people with long-term conditions, to avoid unnecessary hospital admissions, and if they do get admitted to hospital, to help reduce that length of stay and expedite their discharge much quicker. Next slide. The plan was developed after an idea that I had in 2015. With the knowledge that we do manage a lot of complex patients with multiple long-term conditions at home quite safely, and the hope was that if we could develop a plan that would help people to avoid hospital admissions. So we set up a scoping workshop in July 2015, and we involved many people across multiple disciplines across acute care and community care and health and social care. So we involved consultants, Yorkshire Ambulance Service, social services, therapy and community services right across the organisation and across Sheffield. So following that, the OK to Stay initiative was co-designed and developed with patient, public and professional involvement, and that involvement has been key from all those organisations. Since the workshop, we set up regular steering groups that continued with the multi-professional representation from across the organisation, the council, the ambulance service, the commissioning group, Age UK and GPs. Next slide, please. So the principles of the OK to Stay plan is that it's centred around the person, not around the needs of the health services. It's owned by the person, and the plan shows how a person manages all their activities of daily living, and it paints a picture of what is their own unique normal and how they manage at home. The plan includes information about their emergency medication and any wishes of theirs in case their condition worsens. The OK to Stay plan is very clear that it's not intended to replace any of the other care plans that they have in place, like end-of-life care plans or condition management plans. It's there to complement all their other plans and draw everything together in one place. Next slide, please. So this is part of the first page of the OK to Stay plan and the contents of that. And you'll see the first question is, this is what matters to me. And that's a key question that we ask all patients as part of the OK to Stay plan. It also includes their name, their address, who they live with, any significant other people that are involved in their care or looking after them at home. And it also includes details and contact numbers of those people. Next slide, please. The next part shows that it includes a full medical history, any allergies that they may have, and a list of their current medications. It also includes what normal parameters are there for their blood pressure, so what their normal blood pressure is, sitting and standing, what their normal respirations are, normal oxygen saturations, which is pretty key for someone with long-term chest conditions. And there it shows how you can help somebody stay at home. Next slide, please. And this is the second page of the plan that shows, this is the bit that shows how somebody manages at home. And you'll see all the statements are how I get around my home, how I go to bed, how I get to the bathroom, and that just is key for making it person-centred. And this is the part that shows just how somebody manages their day-to-day activities of daily living. Next slide, please. This shows how they're supported to stay at home, so any friends and relatives, any regular carers, including any contact numbers, and their emergency plan if their condition worsens. All of this plan expands as you type into it, so it's not limited to those small boxes. It also shows here that we have gained consent from the patient, and that patient is happy for it to be shared with other people. This is also, it shows details of how to send that plan to our out of hours GP service. Next slide, please. So the plan is completed with the person and their family or significant others, so that anybody who's involved in looking after that person is involved in writing the plan. It's saved onto System 1, which is our clinical system, which is widely used in community and used by many GPs in Sheffield. It's shared and discussed with the GP, so that they're aware of any discussions that have happened with the person. And as I said before, it's emailed to our out of hours GP service. We mark it on System 1 as a high reminder, so as a patient record is opened up, there's an instant reminder that an OK to stay plan is in place. It's reviewed as and when needed, but we do say it's reviewed at least 3 monthly, or if anything changes, if someone's been admitted to hospital and any treatment plan changes, the plan is reviewed. Copies are then printed off once it's completed for the patient, so that they have their own copy, and often family members like to have a copy as well, just in case an admission to hospital is required, so they can take that copy in with them. Next slide, please. So in identifying who the plan is for, it's generally for people who are known to our community nursing services already. These tend to be patients that are housebound and quite reliant on people to look after them. They're generally frail, older adults. They're generally people with multiple long-term conditions, or people approaching end of life. They're people that are generally well known to the services and known to have had multiple admissions to hospital. Or if they are admitted to hospital, they're extended lengths of stay. Or they can be people identified as part of a multidisciplinary discussion with nurses, GPs, or therapy services. Next slide, please. So we didn't receive any funding at all for this project. It was supported by the organisation and by our commissioners, but no funding was given to us. It was mainly driven by the commitment of the professionals that we got involved at the very beginning, and our public representation. We had a brilliant patient representative who attended all of our meetings, and that's driven the project right from the very beginning. Community nursing, therapy and Age UK are now involved in completing the plan. We estimate that completing a plan from initiation of deciding that a plan is going to be put in place to all the liaison and planning is estimated to be about 5 hours a year. That includes ongoing reviews of the plan. We worked that out to cost around £240, and that includes all the prep time, any travel, any non-pay expenses. when you compare that to the average cost of a non-elective admission, that's around between £600 and £3,000 for each stay. So you can see the comparison of how cheap it is to complete the plan. So if you go on to the next slide, please. We have done a few evaluations of the plan since we started using it, and one of the evaluations involved some telephone interviews with patients, carers and their family who have had an OK to stay plan put in place. And you can see there some of the comments, really positive comments from those telephone interviews. One daughter said, my dad hasn't been admitted to hospital since he had the plan. It's helped manage his chest problems. Another said the collaborative way it was done was useful and helpful. Another lady said, who had a lot of admissions to hospital, said, I now know when I am OK to stay and when I do need admitting to hospital. A care home gave us some feedback as well, and they were so pleased with the plan, they would like one for all of the residents. Another daughter said that the plan is a positive force just by its very existence. It opens the door to support and removes the feeling of isolation and helplessness. And that was quite a common theme that went through the evaluation. And next slide, please. So we found with the evaluation, some of the benefits of the plan is that it includes a full holistic assessment. You saw the contents of the plan earlier. That covers everything that you would need to assess for somebody. But we found that it's not just the assessment and it's not just completing that plan. It's the actual conversations that you're having when you're completing that assessment, and any actions that come from completing the plan that make the difference, not just the piece of paper. So it might be that you're assessing how do you manage to get to the bathroom, and that might identify some equipment that is needed in the house. So it's the actions that come from completing the plan that will help make somebody or support somebody to be OK to stay at home. It helps to identify things that might have been missed in the past. And that's partly because we involve not only the individual, but we involve their family and anybody who's involved in their care. And I said earlier, the first question is what matters to you, and including the concepts from the what matters to you conversation just helps to shift the focus from what's wrong with you to what matters to you. Next slide, please. So further benefits of the plan: reduced hospital admissions, which we found quite significant, improved communication between professionals and between the multiple organisations that can often be involved in somebody's care. It improved communication with people and their family. It helped with self-awareness for individuals and increase their confidence in looking after themselves and increase their self-empowerment. Next slide, please. So we have been published a few times. You'll be able to click on the links for this when you get sent the slides afterwards. We were approached by the Queen's Nursing Institute to write a piece in their blog. The NHS England Atlas of Shared Learning approached us to put a piece in there on their website. And we've recently worked with a statistician to evaluate further the OK to Stay plan and published that in the Primary Healthcare Research and Development Journal. Next slide, please. So I'd just like to discuss some of the findings from that study that we published. We worked with John Stevenson from the University of Huddersfield and gave him data from 50 people who'd had a OK to Stay plan completed. And we looked at the 12 months before implementation, data on admissions and contact with emergency services in the 12 months before the plan was put in place, and then a subsequent 12 months to look at a comparison between before and after having the plan. He found that visits to emergency departments had reduced quite dramatically by nearly 2 visits a year. And unplanned emergency admissions were also reduced by approximately 1.28 per person. Next slide, please. So further findings of the study, he found that completing the plan was a positive step to supporting vulnerable and complex people who are cared for at home. It helps an individual recognise the possibility to stay at home and to understand the supports that they could receive from health and social care professionals. And he recognised that there was the cost savings to that investment of initiating the plan. So the £240 that it costs a year, the cost benefits and reduced admissions and reduced attendances at the emergency department were massive. Next slide, please. So I'll take you back to Annie. There was a decision to complete an OK to stay with Annie because of all her admissions to hospital. And Age UK and community nurses completed the plan with Annie. The Age UK independent living advisor started the plan, and she found that Annie had issues with financial abuse. She had built up quite a large debts to a fuel supplier. She suffered with social isolation and reduced mobility. She had no transport, and she was struggling to manage at home. She actually had, even though she had all these issues, she had no home care supporting her at home. Next slide, please. So as a result of Age UK completing the plan, they did a full benefits check and found that she was missing some benefits that were essential for her. They helped her to contact a fuel supplier and helped her with her overall debt management. They supported her to register with a lunch club. They helped her to arrange community transport. They helped her register with home optician and a home dentist. They supported her with access to home care. They helped liaise with social services for that. And they helped her to access some money to buy magazines and crossword magazines. They helped us and supported her to write the OK to Stay plan with her, and that helped her to understand her health condition better. Next slide, please. So the community matron completed the plan with Annie, and she also found that she was struggling to take her medications appropriately. She wasn't using her inhalers correctly at all, which obviously didn't help her chest condition. The matron found that her calls to 999 were mainly when she was feeling isolated and anxious. She found that Annie doesn't really like going to hospital and she finds it quite distressing, but I think because of her anxiety, she felt that that was her only option. She also found that some of her admissions were appropriate because she had had quite a few previous exacerbations that required intravenous antibiotics. Next slide, please. So as a result of completing the plan, the community matron recorded her baseline observations and recorded what her accepted parameters were for that. She educated Annie on her medication and her inhalers and the importance of using these correctly. And she also liaised with home care and educated them to help her support Annie with her medication. She wrote an emergency medication plan and put that in place, including lorazepam for her anxiety. And she referred her to our respiratory mental health team to help her with her anxiety and breathing. She also referred her to community therapy for help with walking aids that she didn't have access to before. Next slide, please. So the outcome for Annie, she's had the OK to Stay plan in place now for 2 years. She's taking her medication and inhalers properly with the help of her home carers. Because of that, her health status has improved. Her breathing's got much better. She's had a lot less exacerbations. She's calling the emergency services much less now. She's had one appropriate admission to hospital, but that was appropriate. We've got examples of how a paramedic has used the plan, read through the plan and read through all her emergency responses and a breathing exercise and helped her to avoid hospital admissions when she has called them. Annie's now much more aware of her own health condition and what triggers that, and recognises when she's becoming unwell. And she knows when to call for help. She knows who to call for help now rather than calling 999. She's much less anxious. She's doing really well with her breathing exercises and her anxiety reducing techniques. She's loving her magazines and her crossword books. She's finding that they help with her anxiety. She's started to gain weight now. She's got daily meal deliveries, so that's helping her enormously. And she's enjoying her weekly visits to the lunch club. She's found that fantastic. Next slide, please. Thank you very much. And now it's open to any questions at this Q&A session. Thank you.